over just a few more things when it comes to the newborn. This is the last of our chapters. So basically, I've talked about this in the previous chapters that babies go through periods of reactivity, and that first period of reactivity in the first 30 minutes that's why we call it the golden hour, and why we want to get that baby on mom's chest and hopefully feeding as soon as we can. And so during that first 30 minutes, you'll see sort of an increase in the heartbeat as the baby gets excited and the baby's alert. And then the heartbeat's going to go back down. And then you have, remember I said babies sometimes just want to sleep for a long time. So that is very, very common. And then sometime during that first day, they'll have another kind of short period of reactivity. And so it's really important to try to get feeding during that time period. So from a respiratory system standpoint, we know the baby needs to start breathing. Those alveoli need to open up. All of those things need to occur for this baby to breathe correctly. Here it goes into it a little bit more. We know surfactant is what helps the alveoli to stay open, right? Normal respirs are 30 to 60 breaths per minute. Babies breathe irregularly and shallow. And it's not uncommon for them to have some periods of apnea. However, both sides of the chest should be going up and down. So you should be noting symmetrical chest movements. You should be noting respirs between 30 and 60 minutes. And because they breathe irregularly and shallow, you need to count respirs for an entire minute. Unlike adults where you can count for 14 seconds and times by 4, you're not going to get an accurate respiratory rate. So it's really, really important that you're able to do that. So then moving on to the cardiovascular system, we know that babies have to make that switch from fetal circulation to newborn circulation, and they're no longer getting oxygen from the placenta, but instead from their own pulmonary gas exchange. So lots of different things have to happen. All of those hormones, catecholamines are released and whatnot. We've talked about these fetal structures before. We need to know they're working correctly. Oh, there's a little baby. Look at the eyes are swollen. That baby maybe came out a little bit fast. The eyes are a little bit swollen there, or maybe it was I wonder if it was a sunny side up baby, so there's a lot of pressure on the eyes. It's hard to say, but you can see the blue hands and feet and a little bit of the molting on the legs, which is not that abnormal after delivery. And so we're going to talk about the hemopoietic system as well. What do we see with platelets and blood group issues and things like that? So there's a little baby on the mom's chest, and the reason why that baby's on that mom's chest is to stay warm. We know that skin to skin is one of the best ways to help babies regulate their temperatures. It's very, very important that we help babies regulate their temperatures, because if their temperatures are not regulated, they become cold stressed, they start breathing fast, their heart rate goes up, and then they start having fluid and electrolyte issues because they start breathing so fast and blowing off all that O2, and so all different kinds of problems happen. This is an important slide. You need to know this slide, okay? You need to know about conduction, convection, evaporation, and radiation. These are the 4 ways newborns can lose heat, and ways we do to and things we do to prevent it. So conduction is transfer of heat from an object to an object when the 2 objects are in direct contact. So if you take a cold stethoscope and you put a cold stethoscope on a baby's chest, you're going to pull heat from the baby. So that's why we warm up things that touch the baby. Convection is a flow of heat from the body surface to cooler surrounding surfaces. So for example, with convection, you're going to help keep away, like, you're not going to put a fan on the baby or things like that. You're not going to put them where it's drafty, because heat comes from the body because it goes to the surrounding air, right? Then you have evaporation. That's why we dry those babies off really quick, to prevent evaporation from happening. And then radiation is a loss of body heat to cooler solid surfaces. So you don't put a bassinet up to a cold wall, right? You try to not have the baby next to something that's really cold that's going to pull the heat. So it's really important you know conduction, convection, evaporation, and radiation, and come up with ways that happens so that you can remember, because that is often on HESI tests. And this kind of goes into what happens when a baby is cold stressed. They need more O2. Their respiratory rate grows up. It decreases causes pulmonary vasoconstriction, decreases the oxygen in the lung, which decreases it to tissues, or you have this peripheral vasoconstriction. Kind of both can happen. You have glycolysis happening, you have PO2 going on, and you have acidosis, and then you have a sick baby who's down in the NICU. So what are the things that contribute to a baby getting cold? Thin skin. They aren't able to shiver. Some don't have a lot of that brown fat that they can burn for that non-shivering thermoregulation. Some aren't able to kind of move their muscles to get warm. They have a large body surface area in relation to their weight. Again, lack of that white subcutaneous fat. They aren't able to take a hat off or put a hat on. They aren't able to say, hey, I'm cold, let's pull a blanket over me, I need more. So with parents, we always say one layer more is usually okay, because remember, babies have a hard time regulating their temps up as well as down. So it's very important not to overheat a baby either. So when we look at the digestive systems of babies, we have to remember they have immature digestive systems. So they are going to often be very, very gassy. That's not uncommon. We want to see meconium passed while they're still in the hospital so that we know that everything is working correctly. Remember, meconium is that first stool. And babies have very small stomach capacities. Really, by the time they go home from the hospital, it's about the size of a ping pong ball. It is very, very small. Remember that cardiac sphincter may be a little bit immature, and so some may have regurgitation. So it's really important that after a baby feeds, you keep them up, upright, because they're going to have that immature cardiac sphincter at the top of their esophagus. And so here's typically what they require, but come on, with breast milk, if a baby's breastfeeding, how are we going to know? We're going to know by their weight gain, and we're going to know by their output. And we'll talk about that in a little bit. Poop is going to go from meconium, black, sticky tar, to transition, and then they're going to have more of what's called a milk stool, and that takes about 5 days. Breastfed babies have yellow gold, really loose stool, and formula-fed babies are more yellow-green. They will not have solid stools until they start taking solid foods, sometimes around 6 months. So one of the things we want to think about is a hepatic system and how important the liver plays in a baby. Babies have very immature livers, and they're not able to function as well as adults. And so one of the things that happens in the liver, one of the most important things that happens, is that's where your bilirubin is synthesized. And so if it's not working as well, you can have, so bilirubin is, caused by the breakdown of red blood cells, and it gets synthesized and excreted through the liver. So if you already have an immature liver system, you're going to end up with this excess bilirubin in your body. And so you have the red blood cells, you have hemoglobin, you have heme and globin, right? So heme is the iron, and that is broken up into the unconjugated bilirubin, okay? And then the liver comes in and it gets rid of the bilirubin, and then you pee or poop it out. However, if your liver isn't working as correctly, that bilirubin is going to keep going back into the body. So the other thing is we need babies to poop because they're going to poop out the bilirubin. Why do we care if a baby has hyperbilirubinemia? Because it can lead to kernicterus. So at first it's going to cause jaundice. You're going to see yellowing of the eyes and yellowing of the body. And kernicterus is a very severe condition. And when we talk about pathological jaundice versus physiological, we're looking at less than 24 hours. So you really want to know the difference between the two. Pathological jaundice is occurring less than 34 hours. And it's less than 24 hours, and it's lasting longer. And then you have a chart that you follow. So it's going up a certain amount per day. And they look at the different serum bilirubin levels. It doesn't involve the palms and the soles. Yes. Could you have signs of bilirubin encephalopathy? That was seizures, those kinds of things. And so, you look at what the direct bili is. Normal physiological jaundice, you're going to see after 24 hours. Sometimes it's even called breastfed jaundice, because we know breastfed breast milk doesn't come in until 3 to 5 days of life. So in the beginning, what do you have? You have colostrum, which is liquid gold. It's that first milk, and it's full of antibodies, but it's a very small amount, because right after birth, really your baby's belly is about the size of a grape. It takes 3 to 5 days for the milk to come in. So what are those babies feeding in? They're feeding on colostrum until the milk comes in. And for most babies, that's okay. However, some won't poop a lot until the full milk comes in. And so as a result, bilirubin is excreted in the stool. As a result, they end up getting what's called physiological jaundice. And they'll be a little bit yellow, but that is different than pathological jaundice. And what causes pathological jaundice? You're going to see pathological jaundice in babies that maybe have ABO incompatibility. Okay, so the RH incompatibility, and then they'll do what's called a Coombs test, and a Coombs test looks for basically like antibodies in the baby's blood type. And if you have what's called a positive Coombs, this baby is going to be at much, so when they draw the blood, they'll say O positive plus negative Coombs, O positive, positive Coombs. If it's a positive Coombs, it's just a different kind of antibody. Those babies are at increased risk for, and it's COOMBS, are at increased risk for neonatal jaundice. And so those babies really need to be treated with lights and things like that and watched very, very closely. Sometimes they'll even supplement with formula to, that's one of the few times that it's really can be important to supplement with formula, because the whole goal is the whole point of doing this is to decrease the chance of kernicterus, which can cause brain damage. Sorry, here we go. So physiological, is a little bit different. It will go away. It doesn't last more than 14 days. So that's jaundice in a nutshell. So then we look at the immune system. Babies are at risk for infection, right? They have some acquired immunity. Okay, they got IgG, IgA, and IgM from mom. However, they really need to, until they start getting their vaccinations, they're going to have less immunoglobulins, to fight infections. So it's really important that everybody is washing their hands who's around newborns. That really, until they get through their vaccination schedule, you don't want anyone who's sick around a baby. And so while babies get a lot of those antibodies from mom, they're still at somewhat of a fragile state. So when we look at the integumentary system, skin and whatnot, what do we see? These are some very common things we see in babies. So babies have immature sweat glands. If you see them sweat, that can be either a cardiac sign or a hypoglycemia sign. That's not a normal thing to see. You can see sort of different moles and things like that. Mongolian spots are very normal. Nevi, again, moles. Erythema toxicum is very normal. Babies often have what's called newborn rash. Erythema toxicum is also called newborn rash, which is, it's like red with a little white dot in the middle, and you see it within the first few days of life. It's very, very normal. Here's a Mongolian spot. So you see this often in African American and some Asian babies, and it's just like a dark green spot on the upper part of their buttocks. Here we go. These are called stork bites. These are like the nevi, just very normal, and they fade and go away. So other things you can see in baby girls, sometimes you'll actually see a pseudomensis. So you'll see even a little drop of blood in the diaper, and that's from the maternal hormones. You might see swelling of the breast buds in both females and males because of maternal hormones. That's very normal to see. Sometimes you'll see discharge from a baby, and here's swollen labia, and here's swollen testes. Again, that can just be from the delivery. Oh boy, this looks like a lot of bruising, right? This looks like a baby that had a lot of bruising coming out. So that baby who's had a lot of bruising is going to be at increased risk for jaundice for sure, because the more red blood cells that are broken down that need to be excreted from the liver, you have remember the heme and the globulin, right? And the heme is going to get reconjugated and become bilirubin again and not be excreted. So any baby with bruises is going to be at increased risk. Also, I'd be worried is there may be like petechiae. Petechiae is not normal. Sometimes you might see petechiae around the eyes or face if it's a really fast delivery. I think we saw that in one of the previous ones. But this would be, I would have this evaluated. Is the leg broken? That does not look very good. Oh, here's one that's absolutely showing swelling of a female and that white discharge, which is not typically abnormal. That's again from maternal hormones. So not something that's typically abnormal. So you might see what's called caput, right? Caput succedaneum. I don't know if I say that right. And that's like cone head, right? So cone head is very normal because you have the baby's head can move. That's why you have fontanelles. You have an anterior and a posterior fontanelle because the plates of the head are made to be able to move, because we know that the skull plates need to be able to move to get the baby out. Caput succedaneum is not abnormal. A cephalohematoma is when you have, and caput succedaneum crosses all the suture lines, okay, so it's kind of that cone head, where a cephalohematoma is just in one spot. It doesn't cross the suture lines. A subgleal hemorrhage would obviously be a bigger deal that you would be concerned about. They're always going to test reflexes to make sure neurologically. So Moro, that's the startle. Babinski, that's where the foot flares. I think you guys probably talked about this in class. There's just, a whole bunch of different reflexes that are tested. Here, this shows you how the skulls can kind of move. So this is more caput. That is a cone head, where a cephalohematoma is more on one side, and that's not dangerous. It will go down in a little bit. If the baby hit their head or fell or something like that, they would always do a CAT scan to look for like an actual hemorrhage inside. This is what they're doing, is they're looking to see if the hips, this baby could have hip dysplasia. So if they hold the baby up and the buttocks creases are not equal, that could be a common of a hip joint thing. And then they do what's called Ortolini's maneuver, where they're actually taking the legs and going and trying to see if they feel a click. And that's what this is. And if they hear a click, then that can be a sign of, again, hip dysplasia. So they do a bunch of different maneuvers to check the hips. We know babies have sleep-wake spikes. Babies will sleep between 6 and 18 hours a day, but they sleep in little 2 and 3 hour blocks. And they sleep in 2 and 3 hour blocks because they need to eat because their bellies are so little, all right? The more premature, they could definitely be, these are some cute pictures of babies. So here's some different states of babies sleeping. The more premature, they're going to be more susceptible to irritable to loud noises and things like that, which is why NICUs are often quiet. We know babies can see about the distance of if you're holding a baby to your arm and back. That's about how far babies can see. They're all going to get a hearing screen test mandated by the state of Illinois before they leave. We know babies can smell, taste, and touch, all of those things, and they recognize mom's smell and things like that. So as just kind of keep in mind why we look at these kinds of things. So hopefully that makes sense. All of these kinds of things can, are how babies can respond. Some babies have good temperaments. Some babies are easy to console. Some babies like to cuddle. Some babies have increased irritability. All different kinds of things that we look at with babies. And I'll let you go ahead and see if you can answer this question. And if you can't, you can go ahead and look it up and do a little research there. Let's see. I'll read it and see. So they have a large body surface area, but heat is not lost in the urine, so we can cross out A and B. Yep, they have a thin layer of subcutaneous fat. Nope, they're not normally flexed. They're more normally flaccid. So it's C. The answer is C. There you go. I figured it out for you. Okay, oops, sorry. That's it. Have a good night.